All right. So hello, everyone, and welcome to the Fall 2020 kickoff of our Grants and Sponsored Research Initiative, or GRIT seminar, hosted by the Research Program on Children in Adversity at the Boston College School of Social Work. My name is Teresa Betancourt. I'm a Salem professor in global practice at the School of Social Work and director of the Research Program on Children in Adversity. This seminar series was founded as part of the U19 Youth Forward Implementation Science Hub, supported by the National Institutes of Mental Health and their global network of U19 scale-up hubs. Our other partners in this work include the Essence and Shine U19 hubs and the University of Rwanda Center for Mental Health. So before I welcome today's speaker, I'd like to announce that we have a great lineup of speakers this fall. On October 26th, we have the team from the U19 Essence Hub, John Naslin, Azaz Khan, and Ritu Srivastava, presenting on design and development of a digital program for training non-specialist health workers to deliver an evidence-based psychological treatment for depression in primary care in India. And on November 16, we have Sunan Bhattacharya, Associate Vice Provost for Design and Innovation at Boston College, who'll be discussing human-centered design. On December 14, we have Dr. Eve Puffer from the Duke University Global Health Institute. We're still working title to be announced. So please visit our website, follow us on social media, and register for our upcoming seminars and stay updated on our programs and job opportunities. We currently are hiring related to our implementation science work on scaling up early childhood development and violence prevention interventions in Rwanda. So if you're interested, come check that out. And now I have the pleasure to introduce today's GRIT speaker, Dr. Margaret Kruk. Dr. Kruk is a longtime friend and colleague and a professor of health systems at the Harvard T.H. School of Public Health. Her research generates evidence on how health systems can improve health for people living in low-income countries. Working with colleagues in Ethiopia, Kenya, Nepal, South Africa, and India, among other countries, she develops novel measures of health systems quality and studies the links between quality and population demand for healthcare, health outcomes, and confidence in the system. She uses novel implementation science methods to evaluate large-scale health system reforms and is the principal investigator of the Quest Centers and Network, a multi-country collaboration to produce evidence for improved health systems. Previously, she chaired recently the Lancet Global Health Commission on High-Quality Health Systems in the SDG era, a global initiative to redefine and measure quality in the health system of lower income countries. She's held posts at the United Nations Development Program, McKinsey & Company, and practiced medicine in Northern Ontario. She has an MD from McMaster University and an MPH from Harvard University. And you can follow her on Twitter at mkruk. So thank you, Margaret. Turning it over to you.
Thank you so much, Teresa. A real pleasure to be with you today. And as we were saying, as folks were joining, it's delightful that we can make this happen. And I think as we will see, hopefully in the presentation and more over in the discussion, there are lots of links between the work that our team are doing in health systems and that your teams are doing around implementation science, around understanding determinants, structural, deep determinants of health outcomes. And so we're excited to talk about that today. So let me just share my screen and launch right in. Okay. So, so what I'll talk about today is how we can use implementation science to build high quality health systems together. So to start with, the problem at hand is one that will be familiar to many people on this call, which is the problem that despite tremendous progress, and we really do have to recognize the huge progress that has occurred in mortality, as in this slide, years of healthy life over the past several decades, I would say 2, 3, 4 decades, there remain major disparities in health. And I think sometimes, the narratives of progress can obscure the fact that we still have dramatic differences in the possibility of healthy life depending on where you are born. And as you can see, Sub-Saharan Africa, South Asia, and other parts, several other parts of the world have not shared in the benefits of progress that we see elsewhere in terms of the possibilities of living well and living long. Okay, so let me just see what's happening. Okay. Now, among the premature mortality that we know is happening every year, every day, some of this mortality can be attributed to failures of the health system. And so what I'm going to just share with you right now are some estimates of the size of the gap in prevention and in treatment that can be attributed to the health system. So let's just start with the fact, this larger pie chart right here, that shows both mortality that can be preventable through public health measures, so broad-based population health measures, and mortality that can be prevented due to health care. We know that these two elements are critical partners on the road to health. And I would say, of course, beyond these two drivers of health are many, many other drivers that Professor Betancourt and your team study, including, of course, social determinants of health and much deeper determinants of health. But when we get to that kind of top of the pyramid and we think about public health and healthcare, what we can see is that in comparison with best performers in the world, among 137 low and middle income countries, looking at 61 health conditions for which we know there are solutions, either prevention or treatment, there are 7 million excess deaths every year happening within these almost 140 countries from conditions that could have been prevented through public health. I'm thinking here, safe driving laws, or air quality, or seatbelt or violence prevention. So these are a huge number of deaths. Furthermore, we found that another 8.6 million deaths happen that could have been, even with the enactment of excellent public health, could have still been saved if people got access to good quality health care. So 8.6 million deaths from conditions amenable to health care. And then we further broke this out into what is driving these deaths from conditions amenable to health care. And it turns out, actually, that non-utilization, so not using the healthcare system, is now a minority of those deaths. It's still important in places where people simply cannot get to clinic. But what we can see is that about 3.6 million of the 8.6 million deaths are among people who don't use healthcare, but a full 5 million are among people who do use healthcare, who do go when who bring their child in when they're coughing and have a fever, who do come in when they have a lump in their breast, but they die nonetheless. Now remember, these deaths are preventable because they have been prevented in other parts of the world. So we know that this mortality is amenable. So quality, to the short and long of this particular slide, is that quality is already a barrier to better survival in many low and middle income countries. And so I think the way to think about healthcare, and again, I'm recognizing here that healthcare is just one part of the equation of health, and I would say probably a minor part. So those of you working on education and community integration and employment, I think are doing the really important work. But nonetheless, people get ill. And when they do get ill, we need two ingredients to be there for the health system to promote health. And those ingredients are the use of healthcare, the appropriate timely use of healthcare, and that the healthcare has to be of sufficient quality to convert that visit into clinic into health. And so this is why we're emphasizing quality as a huge driver of health. Teresa mentioned that a couple of years ago now, we published a commission report on high quality health systems. This was a huge group effort with commissioners from 14 countries. We had an incredible group of providers and policymakers and academics to working together to describe and define what do we mean by quality, how do we measure it, and how do we actually think about improvement, which is going to be the focus of what I'll be talking about today. I hope I persuaded you that quality is not some kind of problem for tomorrow. It is already a binding constraint to progress in our health ambitions and in our work on improving health globally. But I just want to emphasize with this slide that it's only going to get more important to think about high quality systems. Why? Well, because the health needs in every country are becoming more and more complex. You know, it used to be that every fever was malaria, but it's no longer the case that every fever is malaria. Now a fever could be COVID. Now a fever could be pneumonia or TB. And there are more and more complex needs that are making themselves felt, and people are coming forward to the health system with these needs. And I'm not even talking here about the many issues that your team are working on, including, for example, mental health and well-being. People have every right to expect some response, a positive response from systems of any level of resources for these issues. And that brings me to rising expectations. In an era where everyone has a cell phone and everyone has a cousin living in town, it is no longer the case that people are going to put up with minimal healthcare, basic clinic that might be open between 9 and 1 and where there's almost nothing there. And certainly the staff may be struggling to deal with some of the conditions that come forward. So everyone's expectations are rising, they're converging, and people are demanding more from their health systems. And finally, a mathematical fact is that as we have achieved better outcomes in many countries, the currently prevailing level of disease and illness is such that actually additional mortality gains are simply harder epidemiologically. And so residual mortality is harder to avert, requires greater skill, greater knowledge, and a greater system response than simply treating, let's say again, to come back to my malaria example, simply treating a simple malaria episode, which can be done in one visit. All right, so how do we think about high quality health systems? What are they? I want to start off by saying that health systems, we need to reorient how we look at them. I think health systems often seem like technical entities run by doctors, sometimes policy folks, but actually health systems are ultimately a social contract, a social system, and they are for people. They are for the users. And a high quality health system optimizes health by doing three things. It consistently delivers care that can improve or maintain health. By consistently, I mean not on Tuesdays in the capital city between 9 and 3, but at any moment, the system does its very best to improve or maintain health. By being valued and trusted by all people, and by responding to changing population and changing epidemiology. And here's this third point is extremely relevant at this very moment. How does the health system respond when the epidemic comes? How do we think about the responsibilities of the health system in this moment, not just to COVID patients, that they're extremely important, but to all of the people coming forward. This is really embedded in this third point about not being a pile of bricks or a bunch of clinics, but really being a responsive system. And so we created in the Lancet Commission this high quality health system framework that really emphasizes where we should be looking for performance measures. And that place is up here, is up here in the processes of care and in the quality impacts. So simply put, a health system that is working for people produces two types of benefits, two types of outcomes. Some of those are good processes where there's competent care, good user experience, and a competent system. And in turn, those processes produce better health, confidence, and economic benefits, keeping people productive, keeping kids learning, and making sure that people don't go broke paying for healthcare is an important impact. So processes and impacts of care are where we should be looking to measure health system performance. What's incredibly important in the improvement agenda, however, are these foundations: population, governance, platforms, workforce, and tools. How do we organize these foundations to produce the outcomes we want? I think that's the critical question. And so our commission identified two major research gaps. There are a series of gaps around how we're measuring performance. One just small glimpse I'll give you is that very often countries are counting workers and counting medicines in the cabinet and counting vaccines in the fridge as signs of performance. And we are strongly advocating against those kinds of measures because they do not tell us whether people get better, whether people have had a good experience, whether moms will bring that child back when that child gets sicker. And so that sort of measurement we think is misfocused. But here today, I really want to focus on improvement. And one of the major surprises to us in the commission was just how little we know about improvement and how we are investing in improvement at the wrong level. And so the major improvement recommendation from the commission was that improving health systems at scale will require strategies that go beyond a single provider reminder system, beyond a single clinic infrastructure improvement. It's going to take a political commitment and structural reforms to make that system work. So let me just say a little bit about this. Today, majority of quality improvement, and even it has a sort of acronym, QI, you've probably heard it. When we think about QI, the majority of that is focused at the very local level. And by that, I mean at the health worker, it's targeted at the health worker, at the facility, or the user level. Here we see a review of the literature that shows that actually, if you think about multiple levels of intervention, right? The clinic and provider being the lowest level, the micro level, the meso level maybe being the community, the district, the province, and the macro level being national and structural and policy and financing investments and interventions. We see that the majority of the action on improvement is at that micro level. So the question I think that arises is, does that work? Well, let's take one example of what we would all agree, I think, that is an example of a system quality failure. And that is high rates of newborn and maternal mortality. I'm just showing you here of the newborn and maternal mortality that is happening globally, 80% is in just 2 regions. The other regions, and of course there are lots of babies being born in those regions as well, but even when you look at per capita comparisons, we see hugely disproportionate mortality in a couple of areas of the world. And so this is a set of conditions, newborn and maternal mortality, that we actually know a lot about. And we know just how to get these numbers really, really, really low. And yet there are 2 parts of the world where we are seeing scores of newborns and an excess number of mothers dying. And so you might ask, well, what does work to improve, let's say, provider performance for sick children, for newborns, for others? Let me just share with you a little bit of data. Some of the most common quality improvement efforts are around training and supervision. And actually, the kind of novelty is in combining the 2 of them and saying, you need short training courses and supervisory visits and together, ideally, to get those workers' knowledge up to date and get them working as expected. All right, so this is a review of clinical actions that were observed to be taken by providers in the countries that are listed, from Kenya to Uganda. And what we found is that on average, when faced with a pregnant mom or a sick child, about 40% of the expected clinical actions, the recommended quality actions, were taken on average across these countries. Now, I think you should always be aware of averages, and you should be looking within countries and within regions of countries. But just for the moment, bear with me, and just to know that there were much better performers than 40%, but on average, we saw 40% performance. And you can see the ends here. This is 2,000 moms were observed, 3,800 kids were observed. And what you can see from this slide is that training and supervision had minimal effects on raising the number of the appropriate clinical actions that one would expect for these 2 groups. In fact, there was no significant effect at all in antenatal care. And even when both interventions were implemented, we saw minimal improvement in sick child care. I want to come back to the maternal newborn death example specifically, and cite a very important study that was done by some colleagues here in Boston that looked at improving, again, a bundle of interventions, coaching, measurement, data feedback, and support, providing some equipment, making sure that facilities were not out of stock. And when they did that and tried to strengthen primary care facilities that are doing deliveries in India, and this is a huge study, a study of 150,000 mother-newborn pairs, so 300,000 people, a massive study, and very well implemented. It found that coaching, data feedback, and measurement literally had 0 effect on maternal and perinatal mortality and maternal morbidity. There was no difference between the groups that got it and groups that did not. And so the question arises, why? How are we putting all these efforts into facilities? And these are costly, right? Every facility has to be targeted with these QI efforts. They're costly, they're difficult to scale, and yet we're getting really very little for these investments. And I think this diagram is trying to sort of lay out the challenge here. Where we are right now is on this side, the local, the micro level interventions, facility level behavior change, short-term, local scale. Now, those of you who study behavior change might know more about this, but certainly my read of this literature is that behavior is actually exceedingly hard to change on an individual level. Maybe, whether that's patients, people, it's providers, it's very, very difficult to do that. So perhaps it's not super surprising that just telling providers to do more and better isn't really all that effective. We can, however, think about the macro level and system level change, and thinking about how do we alter the foundations of the health system, the very basic premise, the culture of care, the expectations, the rewards, but also the punishments that are in systems, so that we have a large scale effect. And that's where we think the action is, and that's where we think the science has to go. And so let's come to the science. Implementation science, I think, is a very important role in testing structural changes, those large scale systemic changes that we're after. And why is that? Well, ultimately, we think health systems are complex adaptive systems. And complex adaptive systems, they are systems that manifest their performance on the front line. But actually, the changes are not generally generated at the front line. So you can think about frontline performance by health workers as a manifestation of what's already deeply embedded in the system. So attempts to change frontline performance do not alter the underlying drivers, and therefore they're not likely to be successful, scalable, or sustainable. So just to give an example, if a health worker emerges from college, maybe that person wasn't incredibly motivated to be a health worker, it was what their family pushed them to do. Perhaps that person never met a motivational teacher in their training. Perhaps that person only saw 10 or 20 deliveries, and now this person is alone in a small clinic, asked to conduct a birth according to a checklist that's on their phone. That set of underlying drivers cannot be flipped, cannot be changed simply by having a to-do list. They've never dealt with these issues. They may be scared, they may not be motivated, they may not be paid on time. It is very difficult for that one person to create meaningful change. And so the goal is to shift structures and policies as a means to affect practice, not to focus on the practice as the starting point. So the Commission came up with 4 such recommendations that are structural. They are govern for quality, modernize pre-service education, redesign service delivery, and ignite people's demand, because we think actually aligning with the population in smart ways can be a huge driver of improvement in the health system. So I just want to focus in this talk on one of these structural approaches for quality improvement, and that is redesigning health systems to maximize survival. So this diagram just shows something that may seem quite obvious to you all, which is the following, that actually we need to triage very carefully where services are provided in the health system, meaning that conditions that demand advanced knowledge, that require a large team, that require a body of experience, that require maybe expensive equipment, those conditions need to be treated at the right level in tertiary care. Low acuity conditions, conditions that are not likely to kill you, that are not needing advanced technology, and particularly those that require coordinated, continuous care from someone who knows you over the long run. Low acuity conditions of this nature are very well positioned for primary care. And I would add a lot of the mental health conditions also, I think, could be dealt with. We're learning more and more about that at primary care, likely with some interaction with secondary or sometimes tertiary care, but can be dealt with, maintaining treatment for depression, for example, can be done in primary care. And so to come back to our problem of the excess maternal and newborn mortality, it would make sense, if you think about it, antenatal care, which is a pretty straightforward series of things, can happen at health centers and dispensaries. And delivery care, in which many births are normal, but unfortunately, we don't know which ones are going to be abnormal. And when they are abnormal, they require a system response. They require deep expertise for mother and baby to survive. Those have to happen in hospitals. We can't count on health centers, nor should we, to be able to deal with those. When the woman is safely delivered and the baby is doing well, the family can then be discharged, and then the health center and dispensary, the primary care level, picks up again. So this is the idea of how do we maintain high quality care across the continuum of care. And what we have called this is service delivery redesign. Why are we focusing on this? Well, 40% of babies in the highest mortality regions, sub-Saharan Africa and Asia, South Asia, are born in primary care clinics where the staff simply do not have the system to be able to save a life. And so we think that a system redesign is needed, not more training of those providers, but a system redesign is needed to get women to deliver in hospitals, because complications arise without warning, because when they do arise, you can't count on referral, and you need rapid advanced skills and surgical intensive care in some cases. And again, people can't wait for that. That has to happen within a half hour or less. And so I already sort of explained for maternal and newborn health, how do you rethink the system for those women and those families? In addition to the antenatal and delivery care, let's not forget, you need to think about access and equity to make sure that the women who are farthest from hospitals don't have to, can get to hospitals without going broke. What happens at night? How do we ensure quality and continuity, and also respectful care when they get there? And so it isn't a single thing that one would do to realign the health system. It is multiple things. It is a sandwich. It's a layering of interventions and policies that start with strengthening hospitals, boosting primary care, improving access to care, igniting demand, and updating policy. And we think there actually are important, and implementation science teaches us that we really need to be looking for positive and negative, intended and unintended consequences of any major structural change. And we think there are potential harms or risks to redesign, but there are also benefits to redesign, including, of course, starting with improved survival, but also efficiency in the use of funds. Not every single tiny health post needs to have a delivery bed. Multidisciplinary care teams, maintenance of clinical skills, job satisfaction and motivation, and others. Now, these are hypotheses based on data that need to be tested. And so how would we study this in the real world? It's one thing to lay this out and another to prospectively study this. And I should say, this is not a radical idea, what we're talking about here. The vast majority, in fact, all high-income countries and all upper middle-income countries have already moved deliveries to hospitals, and are now, sometimes they did it so fast that hospitals are over-providing care and over-medicalizing childbirth, which is something else we would want to avoid in sub-Saharan Africa and in South Asia. So how do we think about this in a nuanced way, learning from past examples, but also being very mindful that context matters deeply? So I like the EPIS framework of implementation science. I think it's extremely useful to think about outer context, issues of leadership and funding, that they look to me a lot like our structural factors that we've been studying. I like this notion of bridging factors, that you need people who are intermediaries to bring these new ideas into communities for discussion and robust debate, innovation factors, and of course there's issues of inner context and leadership and so on. And these elements need to be explored in all of the stages of exploration, preparation, implementation, and sustainment. So what I want to do now is just briefly share with you the experience that we had in Kenya in exploring this new idea of service delivery redesign. Again, Kenya is a country where about 40% of babies are born in primary care clinics, where we think it's just the wrong level of care. So in the exploration phase, where we really wanted to probe on this problem of maternal and newborn mortality, which by the way has plateaued, right, has flattened. There was a lot of improvement initially when women were first brought into the health system. And now we see that there's a lot of difficulty in making further progress for the reasons that I think we have documented, and one of the issues is primary care delivery. But the way that we explored this issue in Kenya was in a very it acknowledged the complexity of this problem through a series of national dialogues and discussions, including the launching of the Quality Commission report in Kenya. We had the Kenyan First Lady was one of our commissioners. Having her be part of the commission, thinking about the political implications of these recommendations was very important. We had high-level discussions with the Ministry of Health, but also in Kenya, the Council of Governors is extremely important. Why? Because Kenya has devolved a lot of the management and implementation of health systems to the counties. We had multiple discussions with the Ministry of Health, Council of Governors, and they selected one county, a very large county called Kakamega County, as a place that, we should do follow-on specific data collection to assess the feasibility of redesign. We then conducted this redesign with colleagues in Kakamega County, met with the governor last February, and the governor was very much swayed by the evidence and by the mixed methods study findings that we got, and wanted to move forward in that county with service delivery redesign. And so in terms of the inner and outer context, the outer context is really, really important. The economy, the policy, the services that are available that surround this issue. Maternal newborn health is just one set of conditions inside a health system, has to deal with many. We had to understand the perspectives of users and governments and funders and advocacy groups. Are they going to be for or against these kinds of changes? And of course, in the middle of this, COVID came and everything was put on hold while the country figured out how to deal with this pandemic. The inner context included the health system and Kakamega providers, and of course, consideration of what resources would be required to make this work. So I just want to show you a couple of stats, and this comes from our feasibility assessment. Kakamega Health System has this is the map of Kakamega County. It's in the northwest of Kenya. 2 million people, 70,000 babies are born there every year. High maternal mortality ratio still, and newborn mortality has come down, but is still too high at 19. And what you can see here, those blue dots are actually the circles on this map. All the circles are facilities. There are 205 facilities throughout this county, which is not that big. If you look at the scale there, that's 50 kilometers across, that are doing deliveries. So just right there, you want to ask yourself, wow, okay, are all those facilities able to do a quality delivery? So what we found first is that more than 1 in 4 women deliver in primary care facilities that just don't have any recourse to advanced care. Of all the women delivering in Kakamega County, now we still have many home deliveries in this county, 35%, but of the remaining deliveries, primary care deliveries are almost half of the remaining ones. Okay, so let's just look a little bit about how the system is currently organized. Of the 205 facilities, almost 90% deliver very few babies, obviously, right? There's just so many of them. This is a problem because staff and equipment are thinly distributed, so that the scarce resources of a low-income country like Kenya are very thinly distributed across many facilities. The staff in those clinics cannot retain emergency skills. They do not have access to expert advice and knowledge or expert technology. So this is a real problem. Furthermore, when we looked at, asked providers, how many important maternal and newborn complications have you managed in the last 12 months, you can see the distinction between levels. Yellow is nurses in low-level facilities, managing very few of them, only 10% have seen all 4 important complications. And it goes up all the way to nurses in level 4 or 5, those are the hospitals. So very dramatic differences in experience. We gave a knowledge test on obstetric skills and obstetric complications. This is a globally used test. A 60-item test. Pass score is 80%, I should say. That's been determined to be the passing score. And look at the way that, that providers performed. Clinical officers and nurses had low knowledge, 54, 55%, but even doctors who were charged with deliveries in level 4 and 5, that's hospitals, did not achieve on average a passing score. Some did, but some did not. So we have knowledge problems. We have pre-service education problems. People are coming out without the requisite skill set. But we wanted to know more, what's the support for this idea of redesign inside the system? And what we found was that there was actually a substantial agreement, either strongly agree or disagree, that service delivery redesign can reduce maternal and newborn mortality. And furthermore, that we could do it in this county, that with the right investments, it could be done. And we also conducted qualitative work with the population. Many focus groups were done with women, with traditional birth attendants, with families. And we saw generally a lot of openness to service delivery redesign, to delivering in hospital, mostly because people recognized that you will not have to be referred again if you develop a problem. However, people are concerned about overcrowding. How are we going to get to these facilities? Transport. What about overwork and respectful care? And the way that people are treated is very much on their minds. So this has to be something that is addressed right from the start of this investment, intervention, policy change, if we're not going to experience a rebuttal or a refusal to participate in by the users. So I just want to end by saying, sort of moving back out from this specific example, to thinking about how do we think about the research and development agenda for health system quality. We think there are many, many gaps in improving health systems so that they are health improving health systems, they are confidence building health systems, and those are the kinds of systems we want. And so we need research and development to build evidence, to produce science, and to also expand the number of people who call themselves health system scientists who work on these issues. We know that the redesign analysis found that strengthening hospitals and improving access to care is very important. And we now will be working with the government of Kakamega to identify the innovation and bridging factors that are going to be essential to make this investment and policy change work in that context. And I think it's going to be very important to have an independent evaluation using implementation science approaches to understand what the effects have been. But doing more of this requires more than our team and one county and the governor and the Ministry of Health. We really need to think about how do we point and direct other research units to producing quality evidence for large-scale transformation. And so we have just begun a new initiative called QUEST, Quality Evidence for Health System Transformation, Centers and Network, which is intending to build the evidence base to support such transformations by improving measurement, testing solutions, and creating generalizable knowledge very much in partnership with ministries of health and others in low and middle income countries. I've already mentioned this, and just to say that the idea is to have a center at Harvard, but then to have a number of centers jointly working on these issues, jointly working on the aims of of this agenda, so that the evidence is not produced in Boston. The evidence really needs to be produced in the country, but we want it to be produced in such a way that it maximizes global spread and global learning. So very rigorous, generalizable to the extent possible, and very much trusted locally. I also just want to, and this is really just ending here, but I do want to remind us that in global health, all of us working in this very broad space under this broad umbrella have a responsibility to think critically about how we're doing the research. And we, but how do we share governance and determine research priorities jointly? How do we make sure the results are not just exciting to journals, but exciting to policymakers, that are relevant to policymakers? How do we elevate research and researchers, creating opportunities for junior faculty, for women, for people who have not had those shots yet, and we don't want them to wait till they're 50 or 60 to be able to publish in high impact journals and speak publicly and so on. We also want to make sure that the findings from the Quest centers are public goods that are freely available. And that is where I will pause. And so thank you very much for the attention and to these many, many slides, and look forward to your questions. Over to you, Teresa.
Great. Thanks so much, Margaret. That was really a tour de force, and I think a sobering reminder for those of us working in implementation science and mental health, who, a lot of times we are still at the level of the provider, the supervision structure, the facility, and how we can go upstream, and how much you know, the lack of attention to those broader system reform issues continue to confine, you know, the impact that we can have. So I think it's really an important perspective. And we use EPIS as well, which is really nice to see, and have collaborated with Greg Ahrens and had him speak in this series here about applying EPIS to global mental health. So I want to now open it up to questions from our audience and see if we can kick off a little bit of a discussion. So do we have some questions? Feel free to raise your hand or unmute yourself. Tesla, you can help me here. I guess while we're waiting, Margaret, one question I had for you. I know that you had done really important work in Liberia on the topic of resilient health systems. And looking at especially the Ebola crisis and how do you come out of that with thinking about how to be better prepared in the future for managing crises. And I was wondering if you could talk a little bit about what was learned in that work and how it applies to COVID-19 today.
Yeah, absolutely. So Liberia is one of the places we both know and love. It's a very it's an incredible place. I've learned a ton there. We tried to understand how the health system responded to what was just this incredibly frightful. And I think we forget this sometimes. It's very easy for us to sit back here and intellectualize Ebola. But when you're in the moment, and I met with the directors of the hospitals and the health system, and their health workers are petrified of coming in and dealing with this. There's really a very human fear element that's driving so many of the decisions that we forget. It's not some sort of neutral policy making or objective, you know, evidence-based making that's in place there. And I think we just have to remember that. So I think, having said that, there was in Liberia, the system really did shut down, sort of en masse. There was just lack of clarity about how this was spread, to what extent should people even be coming in, what do we have to offer them. So it was a shared fear from the health system and a sort of lack of resources, but also the population, of course, just was afraid of reaching out to facilities. I think one of the most profound things we've learned from Liberia is that, and actually it's really teaching us to think about this in COVID, is that some of the distrust, and trust is at the very core, and you've seen me say trust several times through this presentation. I do think it's one of the core responsibilities of health systems to build and engender trust. If they're not doing that, there is no contract, there is no compact between the population and the system cannot do anything for health. So in Liberia, I thought that it was very powerful that one of the ways they ended up rebuilding or building a new base of trust really soon after Ebola or even during was by engaging with communities, not just to listen or talk at them, but to actually bring them into the solution. And I was just really impressed. I still remember a huge number of people gathered in a suburb of Monrovia explaining how the contact tracing was working and how they are going house to house, thinking with people about what is this, explaining what this disease is, and are there symptoms that should be evaluated early, because now we have some things that can help. And those community members felt part of the system, felt empowered. They also had much deeper bonds with the community. And so bringing the community in these ways, I think is a terrific example for COVID, right? When contact tracing, one of the major issues we're facing with that is lack of trust. People don't want to pick up the phone from someone they don't know. But if it's a community member, if it's my doctor, if it's my, it's someone, it's the crossing guard, or it's whoever that I know from my community, it's a very different response. And I know it's hard to do. It's not easy to work with communities. It takes a huge amount of effort. You know it better than very many people, but it is absolutely indispensable in a moment of crisis. And the problem is that we always try to build it in a moment of crisis instead of having mechanisms and ways to connect with communities and a trusting relationship ahead of time, which we think is one of the big takeaways from Ebola.
Great, really important. And we're seeing that now, as we envision a vaccine in the future and who's willing to participate in trials, the diversity of participants in trials, and then what it will mean for people actually taking vaccines once they're available. So Tesla, I can't really see if we have any questions easily from my screen, so I'll need your help here. Do we have anyone who's raised their hand or?
Yes, actually, our dean has submitted a question through our chat. He's asked, could you speak to how you're approaching this work from a complex adaptive systems and focusing on the underlying structures driving relevant behaviors at multiple levels?
Sure, thank you for that question. You know, I've always believed that health systems are complex adaptive systems. They clearly are. They're not linear. They're not deterministic, and they look very different in very different contexts, clearly influenced by at multiple levels. So I've always had that lens in thinking about health systems. I think what really persuaded me that we need to take that approach to improvement is just the abject failure of so many of our efforts on the front lines and on the intersection between users and patients, where we should be measuring how systems do, but we shouldn't be trying to improve there, because it is very clear that those are emergent phenomena that are happening. They are a function of the sorts of structural and foundational arrangements that we have made to train health workers, to pay health workers. What do we expect of health workers? To the perspective of leaders. What is this clinic for? All of those kinds of things dramatically influence what we see on the front line. So when we think about complex adaptive systems, I'm very interested in measuring things at that front line, but really then coming back and saying, how do we get this result? So thinking about the front line as a manifestation, not a cause, and not a source of performance. Yeah, and in terms of driving the behaviors, again, I'm not interested in behavior change for providers as a thing in itself. I would like to understand, how do we recruit providers who are deeply motivated? How do we enable and hone and support that motivation through training so they're not burnt out? How do we supervise those providers, junior providers in practice? And yes, in some cases, how do we punish providers who really step out of line and betray the public trust? All of those pieces are necessary to me to be able to affect meaningful change. It's when all those pieces are pointing in the same direction. As you know, complex adaptive systems need clear aims. When all those pieces are pointing in the same direction, I think that's when we're going to start to see the scale of change that we're looking for.
Great. Tesla, do we have other questions that have come in from the chat?
That looks like that's it for the moment.
Yeah, I think, Margaret, I guess since we have you here, and those of us in this U19 Hubs network that sponsors the GRIT series are coming from a mental health perspective. So I'll take the option of, getting your expertise a little bit more on some of the challenges we face in mental health, because we know that, in terms of health financing in a lot of low resource settings, for instance, we're working in Sierra Leone. We also have a lot of collaborators here from Rwanda. Financing for mental health is, usually a fraction of health budgets, and these are already underfunded health budgets. So I think, even in the Youth Forward project in Sierra Leone, we've been testing a novel delivery strategy, which is integrating evidence-based group mental health into youth entrepreneurship and employment platforms, because ultimately, at least, they've got reach to vulnerable youth in the community. So if we can get those evidence-based interventions to work in that platform and be integrated successfully, we have a chance to overcome some of the issues and the barriers to reaching vulnerable populations. But ultimately, for those to be sustained, they need to have a policy framework that enhances that sort of integration and supports it, and then they need financing. And so we can bring to policymakers evidence of, look, we were able to successfully integrate, and look, here's the impact. But, what else should we be thinking about as we look at the real limitations in financing for mental health as a part of overall health and well-being as we work in very low resource settings?
Yeah, it's a tough one. I think there's so much to overcome there, right? There are also often biases and stigma that are actually not even very thinly veiled, even among policymakers around mental health. So, you know, well, one thing I would say is it's a process, right? You are working on one of the hardest issues. You know, maternal child health have had a lot of spotlight, much as they're an unfinished agenda. I do want to remind us, you know, when we had HIV/AIDS, it was also that same slog that was there in the beginning, where we had to persuade everybody that this mattered. This wasn't some sort of a moral failure. This was a public health priority. Right. And I think some of those same approaches are relevant here too, right? I think. So that's reframing mental health. This is not obviously a personal failure or a choice. This is a health condition, and really having this be recognized in the medical establishment. I think the other piece is that I think your focus on other platforms is genius, frankly, because it's absolutely essential that mental health treatment, right, which does need to be led by the health system or connected with the health system, needs to be reinforced. This is what we're talking about in terms of these layered or sandwiched approaches. And I think this really actually speaks to the structural changes that I'm interested in. I've been focusing on the structural changes in the health system, but you're looking at other platforms and other structures that sustain whatever we can get done in the health system. So let's say somebody needs actual pharmacotherapy, right, for mental health. How is that person supported? How is that person counseled? Where would that counseling best take place? Right. That's an open question. And I see a question in the chat around this issue too, around how do we think about service delivery redesign in these contexts where we have so few, vanishingly few psychiatrists, right? Extremely few psychologists.
2 for 7 million in Sierra Leone.
Right. And yet, so what do? Do we wait 10 years until we produce some more? Well, we should be producing some more. We shouldn't forget that. That is important, right? But the idea of what's the kind of precision role of the health system here? Where is it that it's only the health system that can do something for this person? Who in the health system is the best to do that? I would say that just on the issue of lay workers or minimally trained workers and specialist workers, there should be a sharing of responsibility. And I think one danger I would say that I would look out for is that you don't put everything on the lay worker. They can do a huge amount, but for the population, and we've seen this very clearly in our research, if the population thinks that's where the treatment ends and that's the extent of it, they may not come forward, right? Because they are fundamentally also looking for good quality care. We see that desire for high quality care is there at all levels of poverty, of literacy, of population. So saying, look, the majority of this will be done by these workers we're training, we're overseeing, with an opportunity to see a more specialized person as needed. That there isn't a severing of connections, that we're not just offering them the littlest, the barest minimum. That's really important. I think then in addition, thinking about all of the other platforms that exist around the health system that can reinforce or even become the primary platform, frankly, as you're experimenting with for treatment. I would just say, I think there's a danger in putting too many of our chips and too much faith on a single, approach, whether it's, the workforce will be, the workplace will be the main thing. People don't think that way. People have tremendous value, place tremendous value and expertise, and in healthcare, often those are some of the most trusted people in society. And it's important not to cleave those things, make them separate, but show the interconnections.
Yeah, definitely. And Ryan, I saw that Margaret touched on some of your questions, but do you want to unmute and ask any part of that still remains?
Sure. Hi, I'm Ryan Borg. I'm the U19 Youth Forward Program Manager. So I work on Teresa's study in Sierra Leone. So my question was really coming from our own experience doing our study there, where I was thinking about what you said towards the beginning of your presentation about how we've tried to do a lot of targeted training and supervision for lay workers or healthcare workers. and that the individual behavior change that has to go along with that is always very challenging. So if you're taking the approach of trying to train people to provide services in a place where these services aren't available otherwise, besides that training and supervision piece, like, I'm curious to hear your perspective on like what are the higher level areas we could be targeting from what you were saying about system redesign.
Yeah, so I do think that thinking about the continuum of care is one big one, and actually signaling that very clearly to the population you're working with. So here are the health workers that we have for you. We're very confident they can do this work. They've received this kind of training. We shouldn't assume, I'm struck over and over by kind of our reluctance populations have to use lay health workers, increasing reluctance, and it's understandable. You know, I remember a health worker in Nepal telling me, frankly, I wouldn't come to one of us. You know, I would want to go to, right, the city if I could. And so it's very important to say these people who are available to you, they're going to form a bond with you. And then we have this other layer of care that would be available, you know, so again, those linkages and making clear that you take their desire and really, I think, very reasonable desire for high quality care seriously as best you can. So I think that's thing one, that it's always connected to the rest of the system. I think another piece of the structural approach in your case is to think about those lay health workers and not think about them at this moment in time and what necessarily they'll need to do the job. Of course, that's important. But what is their career trajectory? Where are they coming from? What are their motivations? And how can we get them to, even within your program, advance and become, you know, maybe get additional training? Is there a subgroup of them that can become nurses or become mental health nurses, or, you know, because that's also signaling that you value, again, that expertise and you value them as people. And I think what you'll see is it'll bring in a different kind of lay health worker too, to your door, right? Who values who may have a deeper engagement with these issues than someone who's just doing it for the per diem or for the daily salary. So those are just two thoughts. I could go on, but you're really the expert in your area, and I'm glad that you're thinking about the broader context. And I think that's just critical.
Great, thank you. We had another comment from Joseph in Rwanda, who was talking about the importance of equipping others to address mental health challenges and sort of that cross-fertilization. And I think, you know, lay workers, but Rwanda has actually been one of those countries where they've tried to do so much that the government, very rightfully, Ministry of Health, has said, we can't put so much on community health workers. And even in some of the child protection work we've been doing now on preventing violence, we're now working with community child protection workers, which were part of deinstitutionalization, rather than the community health workers, but they all work together. So when you see someone's off the Mutuelle, or there's a referral for malnutrition, acute feeding programs, they're working lay worker to lay worker, but there are different, you know, opportunities there, but connecting those all up to a system is really important. And I guess the important remaining question here is about how to get government buy-in. You gave that wonderful example of your work in a particular region in Kenya and how there were commissions launched and sort of a process. For those of us working in places, Rwanda is very different. You know, the level of engagement we've had from the Rwandan government and our work has been tremendous. But learning for other settings like Sierra Leone, where it's been harder to get government engagement and there's been turnover, and you know, a lot of competing priorities. You know, as we tried to advance mental health, we had the Ebola outbreak, right, and then we had COVID-19. I think it's a sign of success that our team was called in to the COVID-19 psychosocial response. So they were starting to be recognized as, you know, being able to speak to that. But how, especially in fragile settings, do you ensure government engagement and continuity?
$1 million question, Teresa. I think it's hardest, obviously, in those settings. It's hard in any case. For one thing, just a small point, but completely central to the challenge is the turnover, right, of people in ministries. So, and especially in a fragile setting with a conflict or a crisis underway, you know, people are going to leave. So it's super tough. I don't have any magic bullets for this for sure. The one thing that I always think about is, in entering maybe a new area or a country that we know a little bit about, is to think about how can we build out the group of people who have a stake in this answer. So I'm always thinking that. And so in Kenya, I didn't know all the political structures, for example, that were there. For instance, the Council of Governors just kind of crept up on us. It became clear very quickly as we sat and talked with people about how Kenya is working. It's just a lot of listening. How does it work? Who makes decisions in the counties? It became very clear that while the Ministry of Health sets policy, the Council of Governors is the one that gives the go-ahead on whether this is going to go anywhere. I did not know that. I did not appreciate the power that they have, and they have a separate health section. And the council. And so one of my strategies always is to work with technocrats and not the the political appointees, because they can be so readily, even the technocrats leave, right? But within the Council of Governors, who is on the kind of health committee, and how can we get not just one, because that person can leave, right. Can we get a couple of people involved in the early phases? They are part of the kind of brain trusts of the project. Mm-hmm. We have regular calls with them, and it's now become, so when COVID came, as just an example in Kakamega, when COVID came, and by the way, of course, the Minister of Health changed in Kakamega just in the last, in the middle of COVID. I'm like, this is the last thing we need right now, because the previous person was so great and so committed. The new person is not a health person. They don't know what, you know the story. Now the Council of Governors that feels the pressure to get the new health minister onto this agenda. Yeah. I don't have to be doing all those calls. We now have this group of supporters, including inside the Ministry of Health, who see this as their thing. Yeah. It's not my thing over in Boston, it's their thing. And that's the dinners and the discussions and the things that is so difficult, of course, are so difficult to do remotely. Yeah. The trust building, but the real listening and saying to them, what are the issues and how can is this an issue? We start with a common understanding. This is intolerable. This issue of stagnant newborn mortality is not tolerable. Your president said so, your ministry said so. Right. What are you going to do about it? And then, of course, we have to start there.
That's buy-in. Fabulous. Thank you so much, Margaret. It was a real honor to have you. We appreciate you so much. And thanks, everyone, for joining.
Thank you so much for having me. It was a delight. And keep up the amazing work you guys are doing. Very important. Thank you.
Margaret. All right.
Thank you. Thank you. Thank you. Thank you.